We are now live with Dr. Robert Bransfield. My name is Mackay Rippey, and this is the Southern Tier Lyme Support hosted evening about Lyme disease, and particularly brain inflammation and Lyme. It's going to be a fascinating conversation. I'm just going to share my screen very briefly here to give credit where credit is due. Here we go. You always have to narrate when you're doing something with a Zoom. So this is brought to you in cooperation and partnership with Binghamton University and the Southern Tier Lyme Support Group, as I mentioned. We are sponsored by IGenix, which is the testing company, and a local nutritional company called LifeStream. So we're very grateful for their participation. And as you know, Dr. Bransfield is a psychiatrist in private practice, and he has an immense background with Lyme disease, both on the teaching side of things as well as the practice side of things. And he is one of the go-to people in the country when it comes to Lyme disease and the psychiatric manifestations and everything that flows from that, because it's all about inflammation, and when the inflammation hits the brain, bad things happen. So Dr. Bransfield's got a wonderful presentation for us, and then we'll have some time for some questions at the end of it. So Dr. Bransfield, the floor is yours.
Okay, thanks, Mackay, and thanks everyone for joining us. And I'll start with a couple slides to kind of review some of the projects that I've been working on and am working on. And then we'll go from that and just have some discussion and Q&A. So let me see. There. Okay, so a number of years ago, one of the projects that I did a lot of work on was autism and Lyme disease. And these were some of the articles. I think basically, based on this research, maybe 20% of Lyme disease, of autism may be associated with Lyme disease or tick-borne disease, particularly I think regressive autism. What we particularly found with autistic children who had Lyme disease was reactivity of the 31 and 34 band on the Western blot. And those were the ones that were removed in the Dearborn conference. So in many ways, then the connection becomes invisible when you use the surveillance criteria method for assessment. If you look at the full complement of the bands, then you can pick this up. And it does appear that particularly 31 and probably 34 are particularly significant in being associated with inflammation of the central nervous system. So that it makes sense that you would see reactivity of those bands. So these were the series of articles looking at that. And then I looked somewhat at what's the link. And we know that people get Lyme disease and then they get these symptoms, these brain symptoms. And how do you connect the dots? And psychoimmunology is the way the dots are connected. So you get the infection, and then your immune system reacts to the infection, and that's associated with the symptoms. And this explores the details, the devil's in the detail, of how infection causes the immune reaction and what are the details of the immune reaction that then result in the symptoms. And then this is a textbook, it's a second edition, looking at the glia cells and looking at how that shows how infections in general contribute to psychiatric symptoms. And a part of this we did with Lyme disease. So it's not just Lyme disease, but many infections, you see the same process where there's the infection, the immune reaction, inflammation, autoimmunity, and then you see the symptoms as a result. Now, this is a chart that I put up, and I think it's a rather good chart in detailing something that's really very complex. So you have an infection of some sort, be it tick-borne, but it's not just the tick-borne pathogens. You think of your microbiome that's within you. We all have a microbiome, but we're looking at the pathological microbiome. And there's this complex interaction of the tick-borne infection, be it Lyme and other infections, and an opportunistic infections such as viruses and et cetera. And everybody, it may be a little bit different in terms of what their complex interactive infection consists of. Then that provokes the immune system. And by provoking the immune system, that causes symptoms. But some symptoms are a direct result of action of the infective organisms. Then you get symptoms, and the symptoms then result in disease progression, which stress the person. And then when they're stressed, they're more immunocompromised, and then the infection take hold better, and it's a vicious cycle. And Lyme denial adds to that. It's like gasoline on the fire. So this is the vicious cycle. And if you think of this pattern, you could intervene at any one of those areas by looking at reducing the pathological microbiome, looking at the immune reaction, reducing the symptoms, reducing disease progression, reducing chronic stress that makes someone more immunocompromised, and education to reduce the Lyme denial that stresses out a lot of patients. One article, and this is the article I think that I wrote that probably was most popular, was a suicide article. And whenever I would go to a meeting and we would say, what's the most common cause of death from Lyme disease? And the answer with everybody would be suicide. But a lot of people don't make the connection. And since I wrote that article, it's distressing how many people have been contacting me with stories, and it's sad that many of these suicides might have been prevented or would have been prevented by better awareness and early intervention. Instead of someone getting one dose of doxycycline after they get a tick bite or something like that. So part of that is the biochemistry, and I explained the biochemistry, but also there's the feeling of alienation and having all these symptoms and feeling lost but in the system. Those two things together, both the psychosocial as well the physiological, contributes to suicidality. And my calculation was there's probably a good 1,200 suicides per year related to Lyme disease, and very few are recognized as the association. Then another article was violence, and the average Lyme patient is not violent, but when it does affect a certain percent, and that percent that it does affect can be very significant. So I looked at, I reviewed the Lyme cases that I work with where there were homicides that I evaluated, and I pulled out 50 of my patients that were homicidal and looked at their data and what symptoms did they have that were different, and looked at some of the patterns. And your most common pattern would be poor impulse control related aggression. We call it Lyme rage, but there's also psychotic aggression and on occasion some predatory aggression, where a certain part of the brain is injured and someone shows predatory behavior. Those are particularly the most troubling kinds of homicides. So again, something that we could prevent. Whenever I see these cases where someone commits a lot of homicides and then suicide, often within a family, you think of this pattern. I've seen that on a number of occasions, unfortunately. This is another area that I wrote an article on, and this is intrusive symptoms. And it's something that a lot of people don't volunteer because they feel it seems so strange. And we were talking about this last week with Dana and Dr. Phillips. And so this is something that a patient wrote, and I think it sums it up well. Frightening, stabbing, horrific images, usually of death, dying, pain, and suffering, and terror, killing, episodic, not continuous. You never know when it's going to come. They come and invade the privacy of my mind. So it's a lot like flicking through the channels of your cable box from one horror movie to the next. And it's like, where did that come from? Why do I have that image, that thought, that emotion? It just came out of nowhere. That's an intrusive symptom. And it goes with temporal lobe inflammation. It's very similar to the physiology that we see with post-traumatic stress disorder, like a post-traumatic stress disorder flashback, and treated with basically many of the same meds. So the article that I did, I looked at patients. I found maybe a good 34% of late-stage Lyme patients have these intrusive symptoms. And you can see it associated with post-traumatic stress. You can see it associated with OCD, and you can see it associated, it makes some people suicidal because it's torture. And it can lead to aggressive behavior in some people where they act on these when they don't have the adequate inhibitory capability. Another article I did, and this was 3 years ago, was looking at an overview. So in this, I went through all the different clusters of symptoms, developmental disorder, autism, schizoaffective, anxiety, depression, panic, etc., and methodically went through the medical literature, looking at what literature existed and tried to pull it together and summarize it. And there really is quite a bit of information out there now about the psychiatric, neuropsychiatric, cognitive manifestations associated with Lyme and other tick-borne diseases. Then this is an article looking at what's psychosomatic or somatopsychic or a multi-system illness. And a lot of patients are mislabeled, where someone says, well, you only have 4 bands on your Western blot, so you can't have Lyme disease, so therefore it's psychosomatic. It's all in your head. And so multi-system illness is something that affects the entire body, and you can get brain symptoms, you can get psychiatric symptoms, as well as physical symptoms. Then there's somatic illness, where it's in the body and it causes distress in the mind. And then there's psychiatric illness that then can affect the body. And that might be true psychosomatic illness, where I'm upset and now my body reacts. And maybe some people, they get chest tightness, some people get headaches, other people may get diarrhea, constipation. It's whatever you're prone to. They tend to be lifelong conditions. And then there's medical uncertainty. So you have to have humility in medicine with a complex disease that you don't understand. So this chart shows how a lot of patients who have these complex illnesses are labeled. And to go through the list, all in your head, somatic symptom disorder, somatoform disorder, medically unexplained symptoms, functional neurological disorder, conversion disorder, illness anxiety disorder, factitious disorder, or Munchausen by proxy, functional disorder, psychogenic disorder, compensation neurosis, psychogenic seizures, psychogenic pain, psychogenic fatigue, delusional parasitosis, calling the symptoms merely subjective versus objective, or non-specific or vague, bodily distress disorder, bodily distress syndrome. So it's bad enough to have this illness, but when you have all these things thrown at you, that doesn't help it any. And then the most recent article, or a recent article, is I looked at 100 patients in my database that clearly had Lyme disease. They really had definite cases with CDC criteria. And then I pulled together what their symptoms were and figured out a diagnostic system based upon that. And so from that, and this is in the journal article, and I share these, questionnaires, and it's what I use when I assess people. There's a screening questionnaire, and then a 24-item self-assessment. Now, Dr. Burrascano and Dr. Horwitz also developed questionnaires, somewhat similar. And then basically a 60-item of the more common symptoms. No two people have the exact same symptoms. And then the 283 full assessment that has 800 data points, and then the co-infection screen. So the way I would assess someone is do the full assessment and then say, well, what's your worst symptom? What's your second worst symptom? And what do we attack in what order? How do your symptoms fit together? Now, the average patient who has Lyme had, before they got ill, was maybe 4 symptoms. And the average medical student who was healthy, they had 4 symptoms. The average Lyme patient after infection that I would see would have 82 symptoms. And the average patient who had some other chronic illness was about 22 symptoms. So the big spread, and that's a way of making a clinical diagnosis, because your laboratory testing you can't rule it out with laboratory testing. Then this article looked at the proposed Lyme disease guidelines that now are published by the IDSA. And I looked at 4 parts. I looked at the disclaimer, which is the most critical part. And they basically say, well, these are just guidelines. These aren't standards. So, you can just take them or leave them. Although if they say that, they should act on that. It's either guideline or standard. And if they impose it that this is what everyone should do, then they take the liability that would go with that. Whereas a guideline just is something that might help your decision making, but you can take it or leave it. And a standard in medicine is always individualized judgment. And with such a complex disease, always need that. And then the next thing we looked at is that the whole article was based on the credibility that surveillance definition was necessary for diagnosis rather than the clinical diagnostic criteria. And that's a fatal flaw. Then in the psych part, I was interested in the psych part, and they said, well, there's no association between Lyme disease and psychiatric illness or suicide or violence or developmental disabilities or anything, because there's insufficient evidence, okay? So that's what they concluded. Now, I did a review of the medical literature looking at a good 2,000 articles here. This is what's called a systematic review. It's a formal data collection method that's used in the medical literature. And then I condensed it, and then Lyme and psychiatric illness, there were 1,000 citations, and I broke it all down and then condensed it. And Lyme disease with psychiatric disorders in children, 267 citations. And so basically I ended up with 377 citations of showing Lyme disease, tick-borne disease causing psychiatric illness, and 73 articles showing it caused dementia. And so condensing it further, when you look at the IDSA, they said there were only 4 articles that they found, and 2 supported an association and 2 did not support it. So they looked at 0.4% of the literature and said, well, there's no association. So they cherry picked what they based it on. Now, this is critical, because if Lyme disease causes no neurocognitive psychiatric symptoms, then it's a simple disease. It really is not very significant. But when you recognize it causes suicide, it can cause lifetime disability, it can cause all these impairments, then that tilts your balance in terms of the diagnosis and how comprehensively you'd want to treat it. Now, another was a group of us defining chronic Lyme disease. And just like saying, well, Lyme doesn't cause psych symptoms, there's also a belief system. And belief system is a good phrase in psychiatry. We use it when people have a belief system that's impenetrable. And sometimes we give for that antipsychotic medications. But when there's a group belief system, that's not an option. But this belief that there's no such thing as chronic Lyme. And even though all these autopsies showed it, so this was a comprehensive review of the literature defining chronic Lyme disease. And this is from a group of us with ILADS. And It really was very thorough and very well based in the medical literature. A project I'm working on now is looking at Lyme and addictive disorders and substance abuse and process addiction. That's my current project. And what we often see is, and I've seen this in my practice, and I drew some statistics on it, that the diagnosis is missed, they feel lost, so then they self-medicate. Or some doctor somewhere gives a quick fix of, you're anxious, I'll give you benzodiazepine, I'll give you a sleep aid, drink some alcohol, pain meds, marijuana, and you're seeing a big increase with the marijuana with this way that it's pushed recently, or other substances of abuse. And then, or they may get process addiction, where they get addicted to internet or video games or gambling or shopping or things like that. And then I think there's quite a bit of this. So when we look at, let's say, it's not just the depression, anxiety, but we also have behavior problems. We have where you see a lot of divorce, marital discord, family problems. You see the aggressiveness with some people, and then you see addictive disorders. And lately there's been a big focus on opioid addiction, and they're trying to blame it all on drug company promotion. And so they did all these restrictions against the drug companies. And after they did that, the amount of drug addiction keeps increasing. So there's something else we're missing. So I don't, it's just like with the autism. I'm not saying that Lyme is the number one or only cause of addictive disorders, but I think you have to tease out and address every single cause, and Lyme is one of many causes. Now, it's hard to talk about anything without talking about COVID. So recently, COVID comes up constantly. And the way I like to think of it is syphilis was the great imitator, Lyme is the new great imitator, and COVID will probably be the third great imitator, particularly as we deal with these chronic cases that will develop over time and show in many different forms. And so fatigue is the main symptom, but you see this cluster of everything else. Now, if you look at that pattern of symptom, and this is for COVID, it looks like we're talking about Lyme, right? But it's very similar, because in both cases, you're looking at chronic immune-provoking illnesses. And again, fatigue, fatigue is the most dominant symptom, but you see this very similar complex. There are some differences with COVID. You see a higher percent of loss of smell and taste. You see more pulmonary symptoms. You see prior hypoxia, particularly people that have been ICU units. And you see more of the clotting problems. But in terms of a lot of the common things, you see the anxiety, the depression, the brain fog, the fatigue, very similar. So this was looking at a large number of people, almost 240 patients, and you saw stroke, intracranial hemorrhage, dementia, psychotic disorders, hallucinations, memory loss. And people that were hospitalized were particularly bad with this. This was a study done by Lambert, and there she looked at what are the main symptoms, the number one symptoms. At the top of the list was fatigue. And then she worked her way down. And there's really about 300 different symptoms that people have identified with COVID, but some are more common than others. And you see that with Lyme, and actually there's more than 300, but but the ones in yellow are the neuropsych, and at the right there is from my study that I did, where it's looking at it, the percentages. So it's very, very close. So how are they similar? They're both zoonotic diseases, meaning they're in animals, and then they're back and forth by a vector, be it of some sort, but there's an animal reservoir, like we see with anthrax or other illnesses or plague. They're both emerging diseases. They have variants. Some people, it's no big deal. And I think that happens where some people, it's nothing, it's a mild case. And then they try to use that as a reference point. But other people, it's catastrophic. And that's true with any infectious disease. You can get a meningitis outbreak at a college or an army base, and some people just get nothing, and other people a little sore throat, and other people catastrophic and die. So there's that spectrum because of different vulnerability, susceptibility. And then in both cases, you have the immune reaction that's responsible for the bulk of the symptoms. And they're both multi-system diseases, and it can be chronic in some people. And then there's the question, is it reactivation or reinfection when these people wax and wane? And we use about some of the same off-label treatment. And it's the same quandary. Well, should we wait until there's a vaccine before we treat Lyme disease? Should we wait until there's a vaccine before we treat COVID? Or do we do off-label things and use judgment? And we also see many of the same similar conflicts of interest, where there's people trying to make money off the disease, or people with their ego trying to get a reputation for being in control of the disease. And there's often this battle of your backroom bureaucrats trying to get control versus the frontline physicians who have the day-to-day, year-to-year responsibility for treating these people for their long-term symptoms. And your backroom bureaucrats who never treat a single case portray themselves as the experts that other people should follow. So what happens if you get both? So how does COVID affect Lyme, and how does Lyme affect COVID? What happens if you get both? So this is my hypothesis from what I'm seeing. And I've had a fair number of seen COVID cases and Lyme COVID cases. My basic thinking, if someone has a latent or active case of Lyme and is not under treatment and they get COVID, you can often see an exacerbation of Lyme symptoms. And so their Lyme seems to relapse. So there might be, it provokes, when you get COVID, you probably don't just get COVID. Just like when you get a Borrelia infection, it's not just Borrelia. There's an interactive co-infection going on. So it may provoke other things. And that's why a lot of COVID patients do better when they're given antibiotics. Why would you give an antibiotic with a viral treatment? Because there's an interactive co-infection. That may have a lot to do with the pneumonia. So there are some, though, that are different, where they get the infection and then they get a high fever, and it seems like it might have helped Lyme. Now, I think that goes back to our old finding, and it was how the first Nobel Prize in psychiatry, where a doctor gave malaria to patients with syphilis. They had a high fever, and that treated the malaria. And some people tried that with Lyme. I'm not recommending it. It didn't work out so well. But it's there's something about fever, and I've seen this with a few Lyme patients to get infected ports and get high fevers, and then their chronic Lyme symptoms improve. But then if someone is in treatment for Lyme and then they acquire COVID, they usually do quite well, because a lot of your Lyme treatments are protective against COVID. So that group, it's the people that had more trouble are the people with Lyme who were in remission and not under active treatment. And why is that? But a lot of the things we use with Lyme patients seem like there's evidence that they can work with COVID. Like ivermectin is becoming the number one med, I think, that people keep looking at. Fluvoxamine, an OCD medication. There's a lot of evidence with that. Hydroxychloroquine that a lot of people used early in the epidemic. All the malaria drugs, Mepron, otherwise, chloroquine, Zithromax, other antibiotics, doxycycline, the disulfiram. There's actual research articles. I use a lot of disulfiram in treating Lyme disease, and that there's evidence of that being affected with SARS. Quercetin treatments, any treatment that improves immune functioning, and there's many of them, and the vitamin treatments, N-acetylcysteine, the D3, the A, and then methylene blue comes up with both. So it's, it's like deja vu Lyme disease when we deal with this. It's the same thing where you are trying to think, well, there's nothing really formally approved for chronic Lyme. There's nothing formally approved for the late stage or, you know, medications to treat COVID much, and using your clinical judgment and individualizing it. So what was interesting is that there's this, they hate to use the word COVID. We were talking about that last week, but or chronic with both COVID and Lyme, but it is. So they say post-acute. And when they gave ivermectin to these long haulers or post-acute, it helped their symptoms, okay? And treatment improvement without any symptom was 88%, okay? And then the others, it was higher. So why is it, how can you say it's post-infectious when you give an anti-infectious agent and you get an improvement? That's rather dramatic. So it makes you think maybe, and there are some cases that were proven to have chronic viral loads. Now, again, how much do you rely on the lab test? How reliable is that nasal swab? So you get the nasal swab or the PCR, and if it's negative, does that mean it's not in your body, or was the test not fully representative? Now, here's another thing that adds to that, where these chronic COVID patient, called the truck driver term, long haulers, that some people get relief after the vaccine. So why would the vaccine help if the disease is totally gone, right? Doesn't quite make sense. So both ivermectin and the vaccine seem to help some of these people with these chronic symptoms. That's something to pay more attention to. So how good are we in general at dealing with emerging diseases such as Lyme disease, chronic fatigue, autism, fibro, AIDS, Gulf War syndrome, Morgellons, pandas, mycoplasma, mold sensitivity, et cetera, when there's so many variables and it's a complex disease, a lot of our bureaucracies do very poorly in approaching this. And they've often failed with complex, chronic, and costly diseases. And a lot of times insurance companies fail because they don't want to feel the responsibility of these chronic, costly diseases and go to great lengths to duck responsibility. So what's going to happen in the future? We have this runaway. I think the COVID, not only does the Lyme, but the COVID causes a lot of residual symptoms and psych symptoms. And we know that in the aftermath of COVID, there's anxiety, depression, substance use, insomnia, et cetera, suicidality. We're going to have this big burden on the mental health care system that will overwhelm us. We've been overwhelmed going into this. Yeah. Now it's going to be worse. So how are we going to deal with this? We need like there was the Operation Warp Speed, it was called, to develop a vaccine, but we need a comparable, Manhattan Project, Warp Speed kind of project for the chronic symptoms of both COVID and Lyme. And hopefully that what we see with COVID would shed light. It's the same thing we'd see with Lyme, right? And maybe people will learn from that and see the similarity to. On an area of concern is, I have this hypothesis that in World War I, there were all these horrible infections of all sorts. A lot of that was fostered by all the prisoner war camps and the trench warfare. And that was before antibiotic era. And my hypothesis was it caused a lot of brain injury in a lot of people who then went on to be leaders and led us into World War II. And including Hitler and Stalin and et cetera. So would the same thing happen with this COVID? Would we have millions or maybe a billion people in the world with brain injury from COVID? And how would that impact how people get along in the future? What would that do for world stability? That's a concern that I have. We also see the injury from the shutdown and economic loss. And so that's a bad combination. So although we have with Lyme or COVID or any of these chronic complex things, there's competing interests. People fail to connect the dots. They have what we call silo mentality. They protect their little turf area. We need to work on understanding it better, having effective treatments, and pulling it together and looking at the whole picture and preventing needless suffering, death, disability, suicide, harm to other people, developmental impairments, etc., and economic and non-economic damages. So we need to work together to make this have a good legacy in the future for our patients. So maybe we could now go into some discussion. Okay.
Excellent.
Okay.
Let's do that. For those of you in the audience, if you have a question, please go ahead and click on the little Q&A icon. It should be at the bottom of the screen, maybe at the top, depending on how you have things set up. And go ahead and type the question in there, and we'll attempt to get it answered for you. In the meantime, the point you bring up about refusing to use the word chronic reminds me, you're old, we're both old enough to remember where you used to go to a car lot and buy a used car, right? And now it's a pre-owned car. So maybe we can call people pre-infected.
Well, I guess that's what, when I did my database, I did do pre-infection for their baseline health and post-infection, all right? But they use the post-treatment. It's not really post-treatment when it was an inadequate treatment, like post-treatment Lyme disease.
Yep.
And so it's, what do you call it now? One phrase that emerged is post-acute sequelae. Okay? But post-acute is chronic. Duh. Okay? And sequelae is the chronic symptoms. Now, you could debate whether it's chronic infection or chronic symptoms. That could be debatable. Irregardless, there can be some chronic symptoms. Now, some of these people, I think some of the symptoms do dissipate with time. Mm-hmm. And that was like a belief that was pushed with, for instance, with the IDSA guidelines, as though, well, these are symptoms that then dissipate with time. I don't think, now some people, maybe that does, but that doesn't happen with everybody. And I think with time, they just get mislabeled and called other things, like that big long list that I showed you, all in your head, et cetera, et cetera.
Now, many people with Lyme disease are concerned about vaccines in general. Mm-hmm. Should I get a vaccine? Should I get the flu vaccine? Should I get a shingles vaccine? What is your stance or thoughts about these COVID vaccines and people with Lyme? And I know you mentioned people are actively treated, but...
Yeah, well, that comes up as a question a lot. And if you look at what are your options for dealing with COVID, all right? Now, one option is live under a rock, but how long can you do that? And some people can do it more comfortably than others, but people who have social anxiety and OCD, they may sometimes like that, and then it's hard to come out from under the rock. And so that's social distancing. The mask, that doesn't really do much. There's not a lot of evidence. We do it, but it's, and then we think like pre-exposure treatment. And I think that's really a pretty good option. And if you look at a lot of the countries that have done well, they did that. Like Peru and even the state with the worst death rate is New Jersey. Mm. And New Jersey had a higher death rate per population at like 2,900 per million than any other country. Now, just recently, Hungary surged ahead. So they're also around 2,900 per million, a little bit ahead of New Jersey. But New Jersey had a higher death rate than most of the all the underdeveloped countries in the world. So somehow they were doing something right that we were doing wrong. And they were doing more like, for instance, the African countries with the malaria treatments.
That's right.
That was protective. And I think we didn't do that. We didn't do pre-exposure preventive treatments enough. Just like our Lyme patients that are under treatment, they did quite well. And, but it was hard for people. There was a tendency to fight that. And there was a group, FLCCC, Frontline Critical Care, COVID Critical Care Consortium, doctors. And in many ways, that's the counterpart of ILADS for COVID, where they're the doctors who are treating this. They're the doctors who are in the ICU units treating these patients all day long. And they're not the people that people go to for the interviews on TV. You know, they interview someone with CDC or NIH that never treats a single COVID patient.
That's because they're too busy treating people. They're not
Yeah,
available.
yeah. But they're the experts, and they recommend a lot of these preventative treatment. Now, if you're hiding on a rock, you don't need a preventive treatment. But if you're in a situation where you're interfacing with people, it's a good thing to do. So that's an option. And then I think because it's so prevalent, it's just a matter of time until you're going to get COVID, because it's everywhere. How can you avoid it? I think any reclusiveness or social distancing is only going to delay the inevitable. So it's a matter of time till anybody's going to get COVID. And so would you rather have a vaccine, or would you rather have COVID? Or would you rather take the prophylactic, pre-exposure preventive treatments? Or would you rather kind of wait, and then if you do get it, take treatments quickly? And it's critical to take it early and be prepared to take it if you start getting symptoms. And I was carrying around a bag of things to take. If I started to get it, I had it all ready to take. And I never needed it, but it was there. And I think that was a smart thing with oximeter and all that. So when you get the vaccine, you're exposed to a very small part of the virus. But when you get the infection, you're exposed to much more of it. So would you rather be exposed to that very small part of it, or would you rather be exposed to the whole virus? Because it's a matter of time until you're going to be exposed. Unless you live, hide and reclusive. So I think it's better that people get it. But I think another thing you can do is do the prophylactic treatment or the social isolation, and watch the evidence as other people are being vaccinated, and how's that falling out? How's that developing? And what vaccine seems to be safer than others? And people that are hesitant would look at that. But I think it has to be, you can't coerce people into doing it. And I see that, like with the colleges.
That's true.
You can't do that with any medical treatment. I can't say, well, you have to do this treatment. I'm deciding it for you. A person has a choice, and they need informed consent for acceptance and or refusal for treatment. So someone who's hesitant may want to wait and see. We're seeing the numbers drop now as the summer approaches, and there's a bit of a seasonal pattern, except when you're in, let's say, Arizona, places where then people go indoors more because it's 120 degrees, then the numbers increase, okay? But when you're in a moderate climate, they tend to improve, and it probably is a D3 with sunlight, and there's a number of reasons for it, and humidity. So I think the vaccines seem reasonable, and then probably when you wait long enough, you'll be able to choose which vaccine you want. In the early part, you would get whatever one you could get. I was vaccinated. I thought the risk of the disease for me was greater than the risk of the vaccine. There's also statistics looking at the older you are, the more it leans towards getting the vaccine. Mm-hmm. And the younger you are, the more questionable, the more there may be concern of an adverse reaction to the vaccine because the risk of the disease is not so great. And you have a more robust immune system, and maybe the risk of the vaccine might be greater. So that's something that could be more iffy in very young age groups. But the older you are, the more the evidence is you should get it. And your problem can be if you have a weak immune reaction, if you're immunosuppressed, if you're on immunosuppressant drugs. But I think if you have Lyme disease, I've seen enough Lyme patients who were not under treatment, who relapsed, and then their Lyme relapsed, I think they're better off getting the vaccine. And
Thank
if I
you.
see evidence different tomorrow, I'll change my mind tomorrow. But that's my position.
Excellent. Thank you. We have a question from Kelly, and this goes back to it's sort of on the same lines, but she has been told that someone with chronic Lyme should not donate blood or be on an organ donor list.
Babesia, probably. Was it Babesia?
No, she mentioned chronic Lyme
Oh,
particularly.
chronic Lyme.
Yeah.
Well, there are people that do look at blood and they see spirochetes in the blood, although we don't know that they're actually Lyme spirochetes. And I don't think it's really adequately studied. I know there's that concern with Babesia and there's attention to it, but I think, there probably are infections that do go, that can be spread in the blood that we don't pay attention to. And because we don't test for everything. It's a good question, and I'm not sure about it.
Okay.
I think like when you find it in tissue and not so much blood, but it could be in blood. So it is a possibility. It could also depend on how sick you are, I think.
So the load of the spirochetes.
Yeah.
Of course. Lynn asks, have you seen people who had Lyme who seem to be successfully treated, but then years later have symptoms seem to appear out of the blue, possibly triggered by an event, and it could be connected to the original illness? This is a softball question for you.
Absolutely. I see it all the time. Now, I think what you realize is that, think of it like chicken pox. All right, you had chicken pox when you're in third grade, and now you're 80 years old and you come down with something and then you get shingles. That was sitting there like a time bomb, and when you were more stressed and immunocompromised, then it got reactivated. I see this a lot, and I think there's no way of knowing when you treat someone and their symptoms improve. They're less symptomatic, so we know that probably their immune system is keeping the infection intact, but we don't know whether or not the infection's gone. So a common thing that I see is someone has that, and then they have an auto accident, they have a life stressor, they get depressed, sleep deprived, and then you see the Lyme reactivate. And I think it's a reactivation. Now, sometimes it's a reinfection, but I think if it's a reinfection, you see the other sequence. You see it begin more with like the migratory arthralgia, and the usual way Lyme begins. But it can be a reappearance of the chronic symptoms. So I think that happens all the time. And I think it happens a lot of times with these automobile accidents that, and then someone doesn't recover and they say, well, I don't see the accident wasn't that bad, but it reactivated something.
Which goes.
And I think when you've been treated, you can never say that you're fine. You'll always have to be alert that it could reappear.
Yes.
And don't think, well, we did the Western blot and you don't have any bands. There's nothing that proves it's gone, right? We can demonstrate your symptoms are gone, but there's nothing that proves it's gone. And I think you should be vigilant the rest of your life that it could come back at any time.
So you mentioned reactivation, and I want to bring up a specific case. Well, not specific case, but a specific instance with concussions.
Mm-hmm.
So there's all the talk about concussions, especially young people in sports, so forth and so on. I've seen a lot when I was coaching, and some people recover. Some of the athletes recover very quickly. Some people it drags on. That's another brain inflammation event. And so do you see in your practice a relationship between concussions and that aren't resolving in chronic Lyme?
Yes. Now, somebody did an article on this about 2 years ago where they did like post-concussion syndrome and Lyme. And I do see Lyme patients who have concussions. Now, It actually, it happens a fair amount because a lot of times Lyme patients are maybe don't have the best coordination. They're more likely to have some fender bender auto accidents. They're more likely to fall and be less coordinated from the neuropathy and hit their heads. So it happens quite a bit. And your post-concussion syndrome is somewhat different than Lyme symptoms, but you see the brain fog and the cognitive impairments and the dizziness and sometimes the nausea. And one that I had followed over a period of number of years, I spoke to that person a month or two ago, and now it's resolved. But when I see a concussion in a Lyme patient, I generally see a longer time for recovery. It's a double whammy when you have two things that are so close together. And it's a hard thing with concussion because when you get a concussion, it's the way the brain bounces around inside the skull. And you can have a lot of people with outwardly what looks like a similar head injury, but very different internal injury depending on the way the brain bounces around. And the most fragile area is the tip of the frontal and temporal lobes here. And that's where there's sometimes trauma, and sometimes you see post-seizure seizure activity from that. But it is a tough thing because the two are so close, and I've seen that a number of times. But if you do a Google search for post-concussion syndrome, Lyme, you'll find that article. It's a good article.
I'll look that one up. Thank you. Nan asks, and sounds like a specific case, so we'll put in our kind of boilerplate, we're not giving medical advice disclaimer. But she asked, it sounds like somebody in her family or friend is hospitalized with psychiatric problems. She can't get the medical community to even take a look at Lyme or Lyme Plus or any of the other diseases. And the person's getting ready to be transferred to a state hospital, and where she fears that there's no chance at all to get a deeper look into what might be causing the psychiatric. And she's seen with this person actually when they stopped antibiotics that things got worse, and they put them on the psychotropics and they got worse. They didn't get better.
Actually, I had a case recently and they were transferred to a state hospital, and I spoke to the doctor at the state hospital and was able to continue the disulfiram treatment, and it worked, and the antibiotic treatment. But it's the luck of the draw of the treating doctor. And I think a lot of time, well, psychiatrists in general, I think, are use more of a multi-system approach. So by their training, they're somewhat more open to think outside the box, but it all depends on the given doctor. And they may call in an infectious disease doctor as a consultant, and they're used to dealing with hospital-acquired infections, and your average run-of-the-mill infectious disease doctor doesn't know much of anything about Lyme disease. They really don't treat it. They don't deal with it. It's more a community physician who deals with it. So, they can give them literature, they can encourage that, but a doctor often has discomfort going outside their specialty. And I've been in that situation. That's how I got started, where I had somebody in the hospital and a bad Lyme case, and nothing else was working, and only the IV antibiotic worked. And it was life-saving for that patient. And they were considered cured because they had prior treatment, and apparently they weren't. But you just want to, anymore, general hospitals are short-term. It's the way the insurance system works. Mm-hmm. And then if it takes long-term, often they end up in a state hospital, and it's just a matter of trying to get a rapport with someone who can be open to it. And in dealing with this, and I was talking to a doctor today about a Lyme patient, and they were receptive, and it depends on the doctor. So you have the admitting doctor and the treating doctor. It's really the treating doctor, and Now, it's not either or, because you can treat the symptoms, and that's good. And you don't want to have an avoidance of the psych meds. Now, some people with Lyme are drug sensitive, but some aren't. So, but it adds to your treatment, and then you have to understand about the Herxheimer reaction and gradually ramp it up. But it's hard when someone's in a hospital because they're in command of the treatment, and you don't have privileges to be in that hospital. Right. You can't put orders in, and it's at the discretion. You can send them literature, and if they're a doctor that wants to know more, then I can put them on my list for psychiatrists that they can. And I've done that with doctors, and then they learn more about it.
Yeah, that's a really good point. So don't go in assuming the worst, is what you're saying. Get to know the doctor, and
if you just go in anti-psych med, as though all psych meds are bad, I think that's going to alienate the psychiatrist. But I think the better way is that this augments the treatment. It's an additional avenue that addresses not just the symptoms, but what caused the symptoms in the first place, which could give a better outcome in treatment.
That's such a wonderful point. And I've heard this in people trying to study alternative treatments in the cancer world, somewhere else. There's the standard of care, and the doctors have to follow the standard of care or they're in trouble, big trouble. So if you could talk about it as an adjunct treatment, even if it ends up being the primary treatment that drives resolution of the problem, it covers them as well. So that's a really, really good point.
Yeah. Well, the standard of care, look at what the standard of care in many ways is based on evidence-based medicine. And the standard of care is not what someone dictates, but it's what people actually do who treat the illness. Okay. So it's someone who, like I said, the bureaucrat who writes guidelines but never treats, they really aren't in a position to dictate a standard of care. It's what doctors actually do. Now, evidence-based medicine has three components: the best evidence available, and there's never absolute evidence. And then it's the clinical judgment, and then patient preference. So, and patient preference is a part of that. So if someone says, well, I don't want this kind of treatment, I'd rather that kind of treatment, that there's a reason that you need to respect that. And you as a doctor, you can only recommend, you can't impose unless there's some imminent life-threatening situation and there's legal, support for it. You're just recommending a treatment. You're a consultant for the person's healthcare, even in a state hospital, right? So you have to look at that and not look at, you do nothing unless there's absolute evidence. But people misunderstand what the standard of care is.
Okay. Thank you. Steve asks about his own case here, and he's been on antibiotics for 16 months and antibiotic antiparasitic for Lyme, Bartonella, and Babesia. He's still having his symptoms. One thing that's interesting, I'd like to comment, he's on methylene blue and clomitrazole. And he says they're helping, but he still hasn't gotten to resolution. So can you comment on treatment length and methylene blue?
Well, methylene blue, I don't really, I see a lot of doctors prescribing it. Usually I'm on the sidelines with the antibiotics, and I see someone else I'm working with doing that, and I'm treating more of the symptomatic part of it, the psych symptoms. And, but I think in general, if you've tried a ton of antibiotics and you've only gone so far, then try symptomatic treatment. If you've just treated the symptoms, then try the antibiotics. But if you've kept doing the same thing, you may want to shift and try different things. I think what happens is everybody has a unique susceptibility with unique co-infection mix. So what works for one person doesn't work for another person. And no two Lyme patients are the same. I've seen that with identical twins who both had it. And you just have, when you're reaching a point of diminishing returns, try a different approach. And in general, when I treat the symptoms, most commonly the first thing I might attack is non-restorative sleep. And that usually is associated with the fatigue and the cognitive impairments, and anything that causes distress that makes the person immunocompromised. So if they're distressed by post-traumatic stress disorder, or if they're distressed by depression or panic attacks, then I treat that, and then their immune system is stronger. If they get to deep sleep, their immune system is stronger, because your immune system is smarter than I am. And if I can get the immune system to work better, that'll be able to figure out what to go after better than I can figure out. And and then you're thinking, well, what's making the person immunocompromised? If they're in a constant pro-inflammatory, sleep-deprived, stress state, they're immunocompromised. Do whatever you can so they're not immunocompromised in that way, whether it's meds or changing lifestyle. People often that do poorly are people that are stoic, and they push, and then they're in that high stress mode, and that makes them more immunocompromised and more vulnerable. The people that kind of back off a little bit and let themselves heal can often do better than that stoic, hard-driving type A person.
Interesting. That makes a lot of sense. So here's another question. Have you ever seen people with late-stage Lyme and co-infections have mostly or only psychiatric symptoms, with Lyme being the cause? So if someone has developed a psychotic illness a few years after being diagnosed with Lyme and co-infections, have you ever seen or heard of it being reversed?
Well, okay, so the first part, yes. Second part, yes. Okay. So the first part being, I think we particularly see where it's really just psych with someone who's been partially treated. Okay. So they were given partial treatment, and it's a lot easier to treat the musculoskeletal symptoms than the neuropsych symptoms. You need less treatment for it. And I think that's the problem, because a lot of people that are in infectious disease and rheumatology just look at those symptoms and don't look at the neuropsych that would appear later in the course. Now, in my database, the average patient was like 9 years post-infection. So some people, they just, boom, they took off, and it was a short time, and other people as long as 40 years since they were infected. But average about 9 or a little bit more than 9 years. And so you do see that with people that are partially treated, and it can be pretty much just the neuropsych. Now, the other part about the full recovery, I think if you catch it early, you have a better chance of more full recovery. And there was a good article with Bartonella that Dr. Greenberg and Breischwert did, looking at that with a child who was a straight A student, got severe catastrophic illness, and then it was diagnosed as Bartonella, treated aggressively, and now they're back on track. I've seen that, but I've also seen that if it goes too long, there's too much disease progression and too much damage done, neurological damage, so that when you do treat it, you can't, although you could undo maybe any continuous ongoing infection and further disease progression, you can't undo some of the damage that's been done. Think of it like if you start to treat dementia 5 years after it begins. Maybe if you find something that might be effective, you're not going to undo the past 5 years. Mm-hmm. Your hope is that you slow down or kind of reverse, so things don't get worse. So I've seen it go in both directions, but early intervention, early treatment gives you the better chance, and earlier diagnosis and greater awareness. And it would be nice if more people are aware. All the cases I see are things where mostly where somebody missed the boat and missed the diagnosis. And I think if I look at the cases that I used to see 10, 20, 30 years ago, those people, more doctors missed the boat than is the case now. So I think people catch it sooner now. They're somewhat more aware and than was the case before.
I think that's a good place to put an exclamation point on this conversation and your presentation. Dr. Bransfield, as always, thank you for what you've done, the awareness you're bringing to Lyme disease through psychiatrics. It's such, you talk about an invisible disease. This is the invisible part of the invisible disease. And anything we can do to bring it to light is just going to help so many people down the road. So thank you again.
Thank you, Mackay, and thanks everybody for listening. And I hope it helps. I hope we can have some positive impact and prevent some of these catastrophes that can be prevented.
I think we have.
Okay.
All right. Thanks so much.